Hello, I wanted to do one on algorithms. So, um, when you start to learn these um, rhythms and treatments, a lot of them are based off algorithms. And this is how I learned them. And when I was going through paramedic school, and maybe it'll work for you, and maybe it won't. So you can just disregard this if it doesn't help you, then don't worry about it. So let's talk about shockable rhythms. So your shockable rhythms are going to be VFib, VTach, pulseless VTach. Hold on one second, someone's texting me. So VFib or pulseless VTach, and then I want to add to that word pulseless. And then let's add torsades. And you will learn these. You will learn these. So don't stress out about not knowing those rhythms yet. I'm just going to talk about the algorithms. So I have a shockable rhythm. I use an algorithm that is, goes like this. Epi and lidocaine makes them better. And that phrase, epi and lidocaine makes them better. The beginning letter of each one of those is the medications I'm going to use for a shockable arrest. Hold on, someone's still asking questions. Okay, sorry about that. So, of course, epi stands for epi, and that is 1 milligram every 3 to 5 minutes throughout the arrest with no max dose. The A stands for amiodarone, and we're going to give the first dose is 300 milligrams, second dose is 150 milligrams, and then if we convert, then we will hang 150 milligrams over 10 minutes. We'll hang an infusion. Hold on one second. So let me just separate this by a little bit. So epi, amiodarone, lidocaine is, of course, lidocaine. And that's 1 to 1.5 milligrams per kilogram. You're going to repeat that with half that first dose. And the max dose is 3 milligrams per kilogram. Like I said, you don't even have to know the doses right now. It's just at least knowing the drugs, and you'll fill in the blanks later. The M is for mag, magnesium sulfate, and that's 1 to 2 grams over 1 to 2 minutes. And the last one is bicarb, sodium bicarbonate, and that is a milligram or milliequivalent, sorry, per kg. If you have a shock, of course, I'm not including the shocks, but you're going to shock them at whatever the manufacturer recommendation is, 200 to 300 joules, and then you're going to give the epi, and then you're going to do these drugs in 2-minute cycles, and every 2 minutes you're going to shock them again. So it would look something like this. You're going to shock them, start an IV, an IO, you'll push a milligram of epi. You're going to flush, elevate, circulate that around. And about a minute later, you're going to look at the monitor. It's still in VFib. You're going to shock them. And then you're going to administer 300 milligrams of amiodarone, or that's, potassium channel blocker. Maybe you want a sodium channel blocker. It depends on if you think they have metabolic derangement. So one of the best examples I had of that was a patient that was working out in the gym, and they were running on a treadmill for an hour, and they just had been pouring sweat. So if you think about that, we sweat by excreting salt to the outside of our body. Fluid follows it. So I'm thinking hyponatremia. And so they have low salt levels, I probably don't want to give a sodium channel blocker. I probably want to give them a bunch of saline to replace the salt levels. And so I did not give lidocaine to that one. I gave amiodarone to that. If I had hyperkalemia or some type of potassium issue, I wouldn't want to give amiodarone. So there's some thought process that goes into the drugs you're going to pick. Those are shockable rhythms. Yep, shockable. Epi and lidocaine makes them better. Makes them better. Now, if there is a drug that you can think of in the H's and T's, that would also be indicated. So that's shockable rhythm. Let's talk about non-shockable rhythms. What are our non-shockable rhythms? Well, that would be asystole, systole, a PEA would be a non-shockable rhythm. And of course, PEA is a condition. It's not really a rhythm. So you could have a sinus rhythm on the monitor with no pulse. We call that pulseless electrical activity. You could have a sinus brady on the monitor. We would still call it PEA. So we're really describing the condition, not the rhythm in that case. Asystole is asystole. For non-shockable rhythms in PEA, I use the term PEA. So PEA is PEA. And that is where we're going to consider the problem. I was going to say that don't look right. And the problem means what's the H's and the T's. We're looking for a reversible cause. Give them some epi. And that is one milligram every 3 to 5 minutes throughout the arrest. And then the last one I consider as advanced airway. And there's reasons I would place an advanced airway if I wanted to rule out some hypoxia, if I wanted to secure, prevent any aspiration, or if I wanted to use end-tidal CO2 to monitor the chest compression quality, then I would consider my airway. Okay, so that's non-shockable rhythms and shockable rhythms. What if we had a patient that had a Brady dysrhythmia? Dysrhythmia. I remember the phrase "at the doc eating." Used to be ice cream, but they took that medication away from us years ago. Oh, so when I say Brady dysrhythmia, it means a slow rhythm, usually less than 60, and the patient is symptomatic. Because patients that are just less than 60, they could be extremely healthy. I got a lot of people in Air Force Base that have resting heart rates in the 50s, and doesn't mean we're going to do anything for them. So the only time you're going to treat Brady dysrhythmias is if the patient is symptomatic. So altered mental status, shortness of breath, pale diaphoretic symptoms. If they're not symptomatic, you're going to treat the Brady dysrhythmia. The A stands for atropine. Let me make that less bold. And we can give now, and it also depends on the protocols. At Shaw, we give a milligram. Your formulary might say 0.5 to 1, 0.5 to 1 milligram for your dose, and you may repeat it with a max dose of 0.03 milligram per kg. So essentially, if it's a 100 kg patient, your max dose would be 3 milligrams. The next one, the T, stands for transcutaneous pacing, which is called TCP. Transcutaneous pacing is putting the pacer pads on their chest. You set your rate at 70 and slowly increase your voltage until you get capture. So pacing them. D is for, I'm split the page here. Let me do this. Let's go ahead and split that page. D, the big D here, I'm putting it down for dopamine. But I will tell you, or hopefully people are telling you, that dopamine is kind of going the way of the caribou. There's kind of better drugs out there now, but dope, I mean, it's still probably what you're going to be taught because, the textbooks lag behind a few years. What's going on today? More likely today, you're going to see epi infusions and Levophed, norepinephrine. But this is most likely what you're going to see. Follow your local protocols. Well, we don't even carry dopamine anymore. With our military protocols, we do norepi and push test pressors. So dopamine, and also for the dose, reference your protocols. Mics 5 to 20 mics per kg per minute. 20 mics kg per minute. Usually those lower doses are called renal doses, between 5 and 10. Low dose dopamine does a pretty good job perfusing the kidneys. Dopamine, and then the last one, the doc eating, is epi infusion. And listen, check me on these the drug doses just to make sure I'm not leading you on the wrong path. 2 to 10 mics per minute. That's for an infusion. We're doing push dose pressors with epi. I'll show you, or Shannon or somebody will show you how to draw it up. And we, our protocols, same with the helicopter, we could do up to 3 push dose pressures. It was a bridge to an infusion. So I'm at Shaw, and if we did have to transport, it's about a 15 to 20 minute transport, code 3, depending on traffic. And so usually if I had to do push dose press, if I had to do an epi infusion, I would just do push doses. And because I'm only going to get about 2 in before I get to my local hospital. And even on the helicopter, we would do a couple of push doses. And that was because we had a team, right? And that was why the flight nurse was getting some type of an infusion going on a pump. So bradydysrhythmias, got to be symptomatic. At the doc eating. And then let's see, how about tachydysrhythmias? Dysrhythmia. Well, looks like I spelled that all kind of wrong. Better. So tachydysrhythmias. I remember, or I use this word, ventricles are crazy. I used to, a long time ago when we had verapamil, I did very active ventricles, and that meant the same as this, but you'll see why it's different now. So V stands for vagal. Vagal like a bagel. Vagal maneuvers, and you'll learn what those are. There's a bunch of them. Vagal maneuvers. A stands for adenosine. That whole thing. And it also depends on what your reference material is. Some will say 6 milligrams, 12, and 12 with a max of 36 milligrams. And I've also seen, I want to say AHA has that. And I've seen some that say 6 to 12 milligrams for that very first dose, 12 and 12. And then I think our current protocols with the Air Force, which are pretty liberal protocols, we don't have to call for much. We can only do, we do 12 and 12. I'm sorry, 6 and 12. And then we have to call for orders for that final 12. Whatever. And then the last one is C stands for there we go. cardiovert. So with tachydysrhythmias, that's going to be, you know, a fast heart rate. It can be narrow. It can be wide. So it can be, yeah, just a really fast heart rate. They don't have time for the heart doesn't have time for the ventricles to fill, so it drops cardiac output because it reduces stroke volume. And the heart's not being perfused when it's not able to rest. And again, these should be patients who are symptomatic. It depends on how symptomatic they are. Let's say you have someone that is in a wide complex tachydysrhythmia, and their skin looks fine. They're talking to you, and they're not short of breath. They just feel like their heart's racing a little bit. And you put them on the monitor, you see that wide complex. It looks like VTach. You're going to either have to make a choice. Am I going to chemically convert this patient, or am I going to electro shock them, right? Shock them. So cardiovert them with electricity or a chemical. So I base it off of the patient's condition. If the patient's unstable, I go straight to shocking them. If the patient appears to be stable, I'm going to try some medications first. So for cardiovert, there's two pathways you take from there. One's chemical and one's electricity. And then when you get to there, there's two pathways. One's for narrow and one's for wide complex. So let's say we'll start with narrow complex. We can do calcium channel blockers. So insert your favorite calcium channel blocker there. I've seen people use amiodarone. That's a potassium channel blocker. Sometimes you'll hear of people, some doctors that use beta blockers. So we're using things to try to slow down the movement of those electrolytes across the membrane. And then, so with your calcium channel blockers, like your verapamils, DILT, procainamide, whatever. You already know amiodarone. Okay. And then with beta blockers, you have two different types of beta blockers. You have beta 1 selective, which is called cardioselective. That's your metoprolol low pressor. And then we have labetalol, which is a non-selective. So it will not only slow down your beta 1, you know, it will, those receptor sites, it also hits those beta 2 receptor sites. And if you remember from EMT basic class, what beta 2 agonists do we administer when people are having asthmatic attacks, bronchospasm, is albuterol. It's a beta 2 agonist. Well, this is labetalol is a beta 2 antagonist, right? So it blocks it. So labetalol would not be a good drug for someone who has bad asthma, because we could give them some labetalol because they have a rapid heart rate, and then they won't respond to their albuterol if they get into an asthma attack. On the electric side of the house, rock on to Electric Avenue. For narrow complex, let's zoom this up a little bit. We're going to start at 50 joules. We're going to sync them, hit the sync button, shock. Now, the ones that I think they caught me on break during the ventilator lecture, maybe, I use the same for my procedures, whether that's RSI or cardioversion. It's called O, say it isn't so. I make sure I have the O is for oxygen. O say, that's suction equipment. Suction equipment's out, on, ready. I is IV access. I have make sure I try to get 2 IVs. The next I is for intubation equipment. I have all my intubation equipment ready. Out, on, ready, light, tight, bright, white, all that kind of stuff. And then so is sedation. So if I try to follow that too with cardioversion. So if I have time and a blood pressure, I want to give them some Versed or something, ketamine or something that will make them not remember the procedure. Narrow complex, we start, this could be, you know, like an A-flutter or an AFib. And I'm sorry, not AFib. AFib, they put it over in a different category. So we will start at 50 joules, sync them up, shock them. With the exception of AFib, AFib gets 100 joules. My goodness, that's a lot. And I was trained in paramedic school that they will leave your stretcher at 100 joules. And I have seen it where they've been shocked at 100 joules and they try to leave. They're like, I'm out. They're not going to tolerate it without pain management. And then wide complex rhythms, we start at 100 joules. Same thing, sync them up, shock them. So anyway, I think that's most of the algorithms I use for, yeah, VFib, VTAC, epi and lidocaine makes them better. For non-shockable rhythms of PEA, asystole, it's just problem epiatropine. For Brady dysrhythmias, I'm at the doc eating. So atropine, TCP, dopamine, epi infusion. And then for tachydysrhythmias, ventricles crazy, vagal maneuvers, adenosine, and cardiovert. It used to be very active ventricles, which was vagal maneuvers, adenosine, and verapamil. But it was hard to get verapamil for people to understand that's just a calcium channel blocker. I think that's all I got. Just a quick algorithms thing. And I'm trying to think what else you might, when I'm working if you know kind of this playbook, then you can kind of blend in with other cardiac arrest teams. Like, oh, we're in, whatever. Yeah, I don't know. You'll be able to figure it out. Deuces.